Very good evening to all of you. At the outset, I would like to thank Dr. Amitabh Krishna for his round vigilance. Can I have the slides, please? Okay. So, one of the founding fathers of the United States of America, Thomas Paine, he had famously remarked, government, even in its best state, is a necessary evil. In its worst state, an intolerable one. And I believe that this quote sort of reflects the times that we are passing through. But I've said this also because it has something to do with the disease we are talking with, type 1 diabetes. At conferences, we hear about insulin analogs, we hear about continuous glucose monitoring, we hear about insulin pumps, and we believe it's a rosy world out there where patients with type 1 diabetes are living their dream, but that's an utopia. So what I'll be focusing on today is rather the darker side of type 1 diabetes, the reality of type 1 diabetes, and everything and anything that I'll be showing today is work done at the Department of Endocrinology. And at the outset, I would like to say it's not my individual work, it's a team effort. My senior colleagues, my junior colleagues, our students, all of them have had a role to play in the data, some of which is still unpublished, that I'll show you over the next 20 minutes or so. So let us begin with a patient, a 15-year-old girl who came to the diabetes clinic of our department a few years back. She had type 1 diabetes for the last 2 years, but she was on premixed insulin twice daily, which is not the standard of getting type 1 diabetes. She gave history of admission with severe hypoglycemia as well as diabetic ketoacidosis several times in the last 2 years. She was short for her age. Her weight for her age was low, but it was normal for her height. In fact, she had some degree of central obesity, and if you can look at the image, she had a Cushingoid faces, a moon faces, as we say. Her puberty was arrested, and the reason she had come to us was not her diabetes, but because along with diabetes, she had a dull, aching abdominal pain, which on examination was found to be because of a massive hepatomegaly. And when we examined her injection sites, we found there was lipohypertrophy. When we sent her tests to the laboratory, everything was wrong. Everything came out to be bad. Blood glucose uncontrolled, protein was there in the urine, her bone age was delayed because, as I said, she had arrested puberty. The liver enzymes were sky high. She had atherogenic dyslipidemia, and as expected for a type 1 diabetes, at least in some of them, the anti-GAD antibody was high. And we did an ultrasonography of the liver, which confirmed that yes, there was a hepatomegaly which we were getting clinically. So we thought of certain possibilities. These are the possibilities, and we sent investigations, blood investigations. And after sending investigations, we could rule out at least these from the blood investigations that we had sent, and we were left with MASLD and glycogen hepatopathy. The next step was a liver biopsy, and the liver biopsy to the left, extreme left, is the normal in a normal individual, but to get to see on a AG stain. In the middle panel is what our girl had on hematoxylin eosin stain, which was glycogen-laden hepatocytes without any fibrosis or inflammation, and to the right is the PAS stain, which confirmed that there was glycogen in the hepatocytes. Now, if there is glycogen in the hepatocytes, you have a syndrome which is called Mauriac syndrome. And the reason I am showing it is because Mauriac syndrome is an exception, it's not the rule. It happens only when your blood glucose is not controlled, and at the same time, you have supraphysiologic insulin being given to you, because she was on premixed insulin. She was receiving very high doses, had insulin injection site lipohypertrophy, so possibly absorption was not taken proper, and she had episodes of hyperglycemia as well. So it reflects the fact that in our country, as in some other parts of the world, we are still far behind when it comes to basic management of type 1 diabetes. If you go to PubMed and do a search over the last 10 years, every second report of Mauriac syndrome is from India. Every second report of Mauriac syndrome is from India, which reflects the harsh reality of diabetes control, type 1 diabetes control in our country. Now, do we need to be concerned? Is type 1 diabetes common in India? While we say that we are on the road to become the type 2 diabetes capital of the world, we are already the type 1 diabetes capital of the world in terms of the absolute number of children and adolescents with type 1 living in the country. Absolute number is the highest in the world. And again, this number could be an underestimation because a lot of our children and adolescents with type 2 diabetes might actually die before coming to clinical attention, die undiagnosed, die because of diabetic ketoacidosis. So there is a big problem and we are possibly not dealing with it properly. So instead of a single patient, we thought of looking at 100 patients who were our follower. Not coming to us for the first time, but were our follower, at least for the last year or so. And we selected 100 consecutive patients with type 1 diabetes coming to our clinic. As of now, we have a little more than 250 patients with type 1 diabetes in our clinic on routine follow-up. We took 100 consecutive of them. And as you can see, most of them were males rather than females. So there's no reason why males should have more type 1 compared to females, which again shows a gender disparity in these individuals coming to our care. So the mean duration was about 6 years of type 1 diabetes. Almost all of them were on basal bolus insulin. 5 of them were not on basal bolus insulin, and I don't have an explanation why, because in our clinic, standard of care in type 1 diabetes is basal bolus insulin, but this is what honest data shows. Now, what did the data show regarding their control? We found that the mean HbA1c was 9.1%, not 7, not 8, 9.1%. Now, behind it, we are a tertiary care center where everyone who deals with these patients is either a MD in medicine or a DM in endocrinology. The patients are provided free regular insulin, free insulin glargine, and investigations are also available free of cost. Of course, we cannot provide them or do not provide them glucose meters or strips free of cost. The lowest A1C was 5.2, the highest was 17.1. So both at extremes, none of which is desirable. If we break up the data into tertiles, we find that 1/4 of these individuals had an A1C of 7.4. So I would say we are doing quite good. Because if you look at the data with type 2 diabetes, 1/3 of Indians have A1C of less than 7. In type 1 diabetes, if 1/4 of your population has an A1C of around 7 or less, I would say we are still doing quite well, although there is a long, long way to go. But what was also concerning is that 1/4 of our patients had an A1C of 10 or more. So 1/4 was very poorly controlled, and this is exactly the problem that we get in type 1 diabetes, where it's very difficult to achieve good control. So from a dark side, we thought of moving to a darker side. We thought of exploring domains in type 1 diabetes which are not usually looked at. These are looked at in type 2 diabetes, but not in type 1 diabetes. And we thought of beginning by looking at sarcopenia. Now, why sarcopenia? We look at the liver, we look at the eyes, the nerve, heart, etc. in diabetes, but we often forget that one of the largest organ systems is the muscle, the skeletal system, which could be affected in diabetes. And we now have data to show that if your muscles are weak or if your muscle bulk is reduced, it could result in increased cardiac disease, respiratory disease, cognitive dysfunction, poor quality of life, increased risk of death as well. And to look at a problem, if you cannot measure it, you cannot improve it. So the basic would be to look at the prevalence of sarcopenia in type 1 diabetes in India, for the basic reason that there was no study in India which looked at the prevalence of type 1 diabetes and sarcopenia. And to do this study, we included 93 patients with diabetes, type 1 diabetes, and 93 age-matched controls as well. Why controls? Because in India, we know that there's a background prevalence of malnutrition which could contribute to sarcopenia. So we wanted to show that on this background, type 1 diabetes had a similar or higher prevalence of sarcopenia compared to age and sex-matched controls. Now, if you look at our study population, everyone was 12 years or older because of the reason that the tests done to look for sarcopenia can only be done if you are 12 years or older. So 1/4 of our population was 12 to 18, the rest adults, and we had a age and gender matched control group as well. So what did we find? We found that someone with type 1 diabetes had a 3 times higher risk, which was statistically significantly more, of having sarcopenia compared to an age and gender matched population. So type 1 diabetes confers a 3 times higher risk of sarcopenia. And we found that it was not the adolescents, but rather the adults with type 1 diabetes who were mainly affected by sarcopenia. Now we tried to look at associations, whether something could predict or be associated with sarcopenia. But to our astonishment, we found that of the factors in our study, neither mean duration of diabetes, nor the dose of insulin, nor the degree of glycemic control, nor the EGFR, nor the IGF-1 was associated strongly with increased prevalence of sarcopenia. So we were in the dark, we are still in the dark. The only light that this study gave us was that there is a high prevalence, much high, 3 times high prevalence of sarcopenia in type 1 diabetes in our population. The reason or association, we need more studies or possibly we need molecular studies to find out what could be the reason of sarcopenia in order to address it better. Now from the muscles, we move to the more abstract part of type 1 diabetes complication, which is psychosocial distress and disordered breathing. Now what is psychosocial distress? It is not anxiety, it's not depression, but it's the unique emotional stress, emotional state of dealing with a difficult disease like diabetes, which is associated with emotions of frustration, emotions of pride, emotions of fear. And disordered eating in diabetes could relate to both binge eating disorder as well as nutritional restrictions to lose body weight. Now, if you look at the ADA guidelines, they very clearly say that all patients with type 1 diabetes should be screened annually for these disorders. But in our clinic, we are often restrained, we have logistic issues because of this. We do not screen our patients with type 1 diabetes for these disorders. But at the same time, it's known that these disorders are associated with worsening of outcomes. And if you can pick up these disorders and refer your patient to a mental health professional, cognitive behavioral therapy, motivational interviewing, and other methods can improve these disorders and result in improvement of outcomes in type 1 diabetes. So how do you screen for psychosocial distress? You have a questionnaire, 20-point questionnaire, and you have a certain score, which if more than 40 denotes psychosocial distress, and it's freely available for download. If you look at the world literature, studies have been done, including studies in India. There's a small study from India which showed that around 50% of patients had psychosocial distress, although the numbers in that study are small, and they did not use this paid scale, they used the older scale. And there's a study from Pakistan, interestingly, which shows that 1 out of 3 patients with type 1 diabetes have psychosocial distress, and it was associated with poor glycemic control. So after doing all the statistical calculations, we found that we needed to include about 140 patients. We could include about 151 patients with type 1 diabetes who did not have type 1 diabetes, who did not have an obvious cause of psychosocial distress beyond type 1 diabetes. And if you look at the distribution of our population, majority were in the 10 to 20 year age group. Again, there was gender disparity, more males were there. 40% of our patients had a BMI of more than 25, which again gives you an idea of the prevalence of increasing obesity in type 1 diabetes as well. More than 9 HbA1c was there in about 60% of our population, as we have shown earlier as well, and most of the patients had a duration of diabetes of between 2 to 10 years. Now coming to the result. In terms of psychosocial distress, about 43% of our population had psychosocial distress. So 4 out of 10 patients with type 1 diabetes coming to our clinic had psychosocial distress. And we found that female gender, age more than 30 years, HbA1c interestingly of between 7 to 9, not less than 7, not more than 9. And those who did SMBG regularly had more psychosocial distress. So SMBG doing it regularly shows the patient glycemic fluctuations which could increase psychosocial distress. So we have to be careful there, counsel the patient accordingly, and particularly look at these high-risk groups, try to pick up psychosocial distress, refer them appropriately to a mental health professional. Now, talking of disordered eating behavior, both binge eating as well as restricted eating, you have this validated, freely available for download score, which again, if more than 20 indicates disordered eating behavior. If you look at world literature, again, there is no study from India, unlike psychosocial distress, where there is a small study from India. For disordered eating behavior in type 1 diabetes, there is no study from India. Global literature, as low as 10%, as high as 60%. So what do you get? Again, the prevalence was about 40%. So 4 out of 10 had disordered eating behavior as well. Like the previous study, female gender, age more than 30 years, and their duration of diabetes more than 10 years was associated with disordered eating behavior. So I would say the take-home message would be that yes, in our DC clinics, we might not be able to screen all our patients with type 1 diabetes for distress or eating behavior disorders, but age more than 30 years, female genders, longer duration of diabetes, poorer glucose control are possibly the ones whom we can shortlist for this problem. Now, talking of NAFLD in type 1 diabetes, we keep on talking about NAFLD in type 2 diabetes, but there is some global literature which says that on an average, the prevalence of NAFLD in type 1 diabetes would be about 20%. From India, we have a few studies, but again, the good studies are still lacking. And if you look at these studies, overall they have shown that it's obesity and insulin resistance which is associated with hepatic steatosis or NAFLD in type 1 diabetes. So in this study, we took 50 patients with type 1 diabetes, of whom 15 were less than 18 years of age, 35 were more than 18 years of age. The mean duration of diabetes was about 10 years. The mean age of this population was 23 years. So what did we get? We found that in our population, 14% with type 1 diabetes had hepatic steatosis, which is in itself quite a big number. 1 out of 7 patients with type 1 diabetes had some degree of hepatic steatosis. And all of these patients had unprocessed nitrogens, all of these patients had central obesity. And when we did a bioimpedance analysis, these patients had a higher tendency to have visceral obesity and higher body fat. On further analysis, we found that the patients who had hepatic steatosis had a statistically significant longer duration of diabetes, more insulin requirement, more obesity, so more insulin resistance, poorer glucose control, and a more atherogenic lipid profile. What was really concerning was not steatosis alone, but the fact that these patients also had more steatohepatitis and higher liver stiffness measurement, although none of these patients had yet developed clinically significant liver fibrosis. Early stages of fibrosis were more common in these individuals, and it correlated with obesity parameters. So if you look at our population, even in type 1 diabetes, obesity is increasing. So some of them have so-called double diabetes, NAFLD, steatohepatitis. Early stages of fibrosis are quite common in these individuals. So we looked at the dark side and the darker side, but possibly the darkest side in type 1 diabetes happens to be the fact that we are not doing the basics properly. Something as simple, although I would not say it's very simple, as proper insulin administration is still not done in most of our patients with both type 2 diabetes and type 1 diabetes. Every once in a while, we get to see patients with lipohypertrophy, wrong injection technique, wrong injection site abscess. So I believe that we need to get the basics right to address these dark aspects of diabetes. And this is something which has been ongoing in our state for some time. It's the brainchild of Dr. Sujoy Ghosh. I am a part of the team as well, where different tertiary care institutes in diabetes have adopted district hospitals. For example, NRS Medical College has adopted Hooghly District Hospital. We have set up a diabetes care team there who are now well equipped and well trained to look after all patients with type 1 diabetes in the district of Hooghly. So we believe that this model will expand in the days to come, and as we go out to the periphery, as we decentralize type 1 diabetes care, possibly we'll be able to do greater justice to our patients with type 1 diabetes. I would like to end with the message with which I began, which is that we look at the bright side of things. We often look at what is shown to us, but only when we delve into the topic better, only when we look at it from our viewpoint, do we get to see the real side of the problem. It's a huge problem, but again, all problems can be solved by taking one step at a time. I believe that if all of us increase awareness regarding these conditions, do the basics properly, we can make the world a better place for our patients with type 1 diabetes. Thank you.